Good evening, and welcome to yet another episode on Elevate Ventilator Management Experience. This is the final module of the three-part series on mechanical ventilator, with the first module on basics of ventilation, second module on advanced ventilation, and we saved the best for today's session, which is on the clinical application of the past two sessions, which includes COVID-19 handling as well. We thank our participants for your overwhelming support for the past two sessions. And today's speaker, Dr. Saneesh, PG, a senior consultant anesthesiologist from Ananthpuri Hospital, Trivandrum, Kerala. He'll be the first speaker of the day. He have authored 2 textbooks in anesthesiology, and he is an American Heart Association certified BLS and ACLS instructor. He manages his YouTube channel, and I hope by now most of you would have had a chance to look into that YouTube channel, which was run by Dr. Saneesh in the channel name Anesthesia Tools, and host an academic website with online version of anesthesiology teaching material. The second speaker of the day, Dr. Anoop Kumar AS, Consultant and Chief Intensivist, Baby Memorial Hospital, Calicut from Kerala. He is awarded the Best Doctor Award in 2018 for his role in identifying and subsequent role in containing the outbreak of Nipah virus in 2018. He is a member of many scientific and professional bodies, and he is an active educational enthusiast as well as a passionate teacher. So we welcome both the speakers of the day to take over the session. Before going to the session, a word of instruction for the participants that we have 3 poll questions. After Dr. Sanesh's presentation, you can access the poll question. You have to come out of the full screen, and you can take the poll questions at the bottom. There are 3 questions. Dr. Saneesh will run that question at the end of his session, but the answers will be discussed after Dr. Anoop's session. So without much further ado, I turn it over to Dr. Saneesh. Dr. Saneesh, all yours, sir.
Thank you very much, Dr. Prabhu and GE Healthcare team for this opportunity to be part of this wonderful webinar series, and thanking one and all participants for your overwhelming response and enthusiasm and support for this webinar series. So we are on day 3, module 3 of understanding mechanical ventilation in the Elevate Ventilator Management Experience webinar series. First half, I'll deal with how to manage weaning from mechanical ventilation and something more about ventilating COPD patients. Mechanical ventilation, we are all familiar with how to initiate right from the time of intubation, how to do the pre-use check. Then you proceed to the stabilization phase. And once stabilization is done, you start with readiness testing for extubation. So you don't want your patient to be on mechanical ventilation indefinitely. That is just to keep the physiology going, to support the systems. As soon as possible, you try to take off that invasive mode of health support system. Okay, so after initiation, stabilization phase, second half starts the all important part of readiness testing, and which ultimately should culminate in extubation in the best of care scenario. So weaning is a form of art, and it is the science of liberation too. In intensive care practice, we take care of A, B, C, D, E, F bundle. Pain management is definitely there. Spontaneous awakening trial and spontaneous breathing trials are there, which we'll discuss further. Choice of analgesia, sedation, delirium management, early mobilization, of course, family engagement and empowerment, everything taken together will produce a good package of intensive care management, especially when mechanical ventilation is involved. As I said before, we need to focus on the patient and his problems rather than focusing much on the sophistications of mechanical ventilation. The mechanical ventilation sophistication, modes, alarms, everything is for your help in assisting the patient recovering from his pathology. How do you assess the readiness to wean? First, the reversal of the indication for ventilatory support. There should be good enough reasons to believe so. The gas exchange should be adequate with the indicators like good PaO2, reduction in FiO2 or oxygen requirement, reduction in PEEP requirement, the pH coming close to the physiological one, Vd by Vt less than 60%, patient not hyperventilating, etc. Definitely patient should be hemodynamically stable also. There should be minimal cardiovascular support, no evidence of cardiac ischemia ongoing, no unstable arrhythmias. And patient, when he starts to initiate breath, you should be preparing yourself to assess the readiness to wean. It is said that more than 40% of the time on mechanical ventilation is spent on weaning the patient from mechanical ventilation. What are the weaning parameters? These are used to predict the weaning readiness. Okay, you assess for three major categories. You assess the ventilatory drive, ventilatory muscle capabilities, ventilatory performance. Ventilatory drive is assessed by the value called P01. Don't get scared. It is the value given in modern mechanical ventilators. Should be more than -4 centimeters of water. It is the airway occlusion pressure during the first 0.1 second after beginning an inspiratory effort against an occluded airway. So that is the checking of ventilatory drive. Then something about ventilatory muscle capabilities. When the vital capacity is more than 10 mL per kg, minimum inspiratory pressure, MIP or NIF, less than -30 centimeters of water. Ventilatory performance indicators like minute ventilation less than 10 liters per minute, maximum voluntary ventilation more than 3 times the minute ventilation, rapid shallow breathing index or RISB less than 105, and respiratory rate less than 30 per minute. How do you do spontaneous awakening trial? It starts with a safety screen. You have to roll out the contraindications like seizures, alcohol withdrawal, raised ICP, moribund status, waiting for withdrawal of life support. Cardiovascular system, you check for shock, high requirement of pressors, myocardial ischemia within the last 24 hours, or if the patient is on post-cardiac arrest hypothermia protocol, you can't go for spontaneous awakening trial. With regard to respiratory system, if patient is ventilator dependent, you cannot opt for spontaneous awakening trial. So is the case with the ongoing neuromuscular blockers use. There should be a checklist. Neurologically, you check whether the patient opens his eyes, looks at the caregiver, squeezes his hands, or put out the tongue. 3 out of 4 would be very much desirable. And then you check the objective indicators like saturation more than 88% on an FiO2, less than 50%, and a PEEP less than 8 centimeters of water. Spontaneous effort in the last 5 minutes period. No evidence of myocardial ischemia in the previous 24 hours. No significant use of vasopressors, no agitation, no evidence of raised ICP. So there should be a protocol. Most of the ICUs will have a protocol to perform this. The inclusion criteria being presence of spontaneous breathing, no planned procedures, no ventilator dependence, and the pain scores acceptable. If everything is yes, then check for the screening criteria. Saturation more than 88% on FiO2 less than 50%, PEEP requirement less than 8 centimeters of water. Patient should be hemodynamically stable and rhythm should be stable. If yes, conduct 1 minute screening for spontaneous breathing trial. Check whether RSBI remains less than 105 and respiratory rate is less than 35. If it clears that 1 minute check, you can proceed with the spontaneous breathing trial for a minimum period of 30 minutes to a maximum period of 120 minutes or 2 hours. If it is a short period of ventilation, 30 minutes of SBT should suffice. If it is a longer period, you need a longer trial period to see whether even off the ventilator support, patient will maintain the oxygenation, ventilation, and airway protection. Okay, so if that is cleared, that means RSBI does not exceed 105 for 5 minutes. Saturation is not dropping below 90% for more than 2 minutes. No arrhythmia. Heart rate stays less than 140% or 20% increase in baseline. You can declare as SBT passed. If SBT is passed, then you can check for the secretions, positive airway leak test. The cuff leak test you can perform, which is not 100% conclusive though. Then record the results and multidisciplinary team decision. We can proceed with the extubation if the spontaneous breathing trial is successful. How do you do spontaneous breathing trial? It is a mechanism used to assess the patient's ability to breathe with minimal or no ventilatory support. Original option was TP's trial, where humidified oxygen was connected directly to ET tube along the TPs. Other options are when the patient is still connected to the ventilator through the circuit. You can do a CPAP trial with the CPAP level equal to the current PEEP level, or you can provide a low level of pressure support, or you can go for automatic tube compensation. Okay, the advantage is since the patient is attached to the ventilator, you can maintain the precise FiO2, and in case the patient fails the trial, they can be quickly placed back on the full ventilatory support, or you can set backup mode settings. Along with the weaning, you need to be vigilant about what sedation analgesia is going on. You should be familiar with the common drugs used for sedation analgesia in the ICU. You should be familiar with the elimination half-life, whether it is affected by renal or liver dysfunction, and is there any possibility of active metabolites accumulating. That also you need to consider before deciding finally on extubation. Pharmacological weaning plan, it's important that sedation scoring and ventilator mechanics both are taken into account, and there should be a caution about polypharmacy and SOS or as needed dosing, which might interfere with your plan for spontaneous awakening trial or SBT. Patients awaiting an spontaneous awakening trial failing an SAT, you can restart sedatives at the half the previous dose and then titrate for comfort depending on which sedation score you are using in your ICU. Now we'll discuss the ventilatory strategies and some technical things regarding ventilating a case of COPD. I think the best option to give these messages would be through a story. Okay, Kahani Sunao, that everybody would like to hear the story. So this is a sample story. A 72-year-old gentleman who was a chronic smoker is admitted with acute exacerbation of COPD, and he is obtended with the CO2 narcosis, respiratory failure. He was intubated in the emergency room and shifted to ICU for ventilation. The question is, how are you going to keep his ventilator settings? So before going something about COPD, we should know what is happening in chronic obstructive pulmonary disease. It's characterized by persistent respiratory symptoms and airflow limitation that is due to airway, ANBAR or alveolar abnormalities, usually caused by significant exposure to noxious particles or gases. It also produces significant systemic consequences. I think last time Q&A session there was a question whether asthma ventilation is same as COPD ventilation. COPD ventilation is not 100% reversible pathological condition we are dealing with. There is definitely respiratory membrane destruction, alveolar destruction. So with each exacerbation, patient's reserve is going to come back, and patients are likely on medications for a long time, for years altogether. So the components of COPD include inflammation and airflow limitation. It can be presented with small airways disease or parenchymal destruction, which is detrimental for gas exchange and the outcome. There may be damaged airways. It can collapse easily. There will be loss of elasticity and reduced force to push air out. That's why patients are straining during exhalation. So the key culprits, bronchospasm, airway mucus collection, and inflammation can cause raised or increased airway resistance and reduced elastic recoil. The increased airway resistance will lead to expiratory flow limitation and changes in FRC and inspiratory capacity, which we'll discuss now. Elastic recoil reduction will lead to trapped volume, that is inadequate exhalation, leading to auto-PEEP, which will cause dynamic hyperinflation, which will result in diaphragm flattening, increased work breathing, and ineffective respiratory pump. Ultimately, these all will lead on to respiratory failure, inadequate tidal volumes, and increased alveolar arterial CO2 and impending altered sensorium, respiratory failure, and the story goes on like that. Just to understand the basics, what is happening, I would like to remind you about the relevant lung volumes. This is the normal tidal volume, and after the normal exhalation, what is remaining is functional residual capacity. So after a normal exhalation, how much you can inhale to the total lung capacity is the inspiratory capacity. Okay. So what happens with the continuous or persistent expiratory airflow limitation is, you can see the airflow limitation happening. The FRC gradually goes up with years of this pathology, and it almost touches the base of the exhalation. Okay, so now from here, if somebody can exhale this much is the inspiratory capacity, from this particular new elevated baseline, they cannot breathe more. To understand how it feels, you can take a deep breath, hold, and then try to take another breath over it. You'll realize how difficult it is. That's what these unfortunate people are suffering throughout the latter half or later decades of their life. Okay. And when the FRC is increased, actually the diaphragmatic mechanics are lost. The curvature is flattened, so there is not much of allowance to contract or reduce the curvature further. So that is the problem with the persistent auto-PEEP formation and the destruction of the respiratory units. It all will lead to inefficient breathing, raised CO2, which will lead to raised respiratory drive, and patient will be agitated and restless. Auto-PEEP I have explained in the last session as well. We'll see how this auto-PEEP works in a COPD patient. So first one I'm showing is a normal patient without any inadequate exhalation. At the end of expiration, the alveolar pressure comes back to atmospheric pressure. Airway pressure is also 0, which is in continuity with the atmosphere, and the pleural pressure is also 0. So there is no airflow happening at the end of expiration. I request all the residents and the junior friends to listen to this part very carefully. Then you will have a better insight into COPD ventilation. So what happens during inspiration, when the inspiratory muscles contract, develop pleural pressure of maybe -5, the alveolar pressure becomes -5, which is much less than the airway pressure or the atmospheric pressure. So there is a gradient from 0 to -5, and there is gas flow in the inspiratory flow happens. Okay, there is not much of extra effort. Fine. Now, imagine a situation where there is air trapping, and due to this air trapping, it develops an auto-PEEP of 10 centimeters of water. This is for your understanding. So when the alveolar pressure is 10, okay, some of it is being transmitted to the pleural pressure, maybe 30% of it. You can take it as +3. This happens at the end of exhalation. Okay, so at the mouth opening pressure, atmospheric pressure is 0. Here it is 10. There is no airflow happening because of the collapse of the airway. Okay, now active inspiration starts. Now what happens is, when the active inspiration starts, the pleural pressure goes negative from +3 to 0, and up to -13 it has to go to make the alveolar pressure -3. Okay, so only when this much effort is exerted, there is a gradient developing between the ambient pressure and the alveolar pressure. Unless the alveolar pressure is less than the ambient pressure, inspiratory flow doesn't happen. So this is the change in work you see when there is an auto-PEEP. When there is an auto-PEEP developing, the patient will have to exert major work of breathing to inhale or to have inspiratory flow happening. Now imagine a case. This is a COPD patient. He has got auto-PEEP. Now you are going to ventilate him, and you are going to apply PEEP, external PEEP, onto his breathing circuit. That means now he is breathing from a different atmosphere where the baseline pressure itself is 10 centimeters of water. So at the end of expiration, the baseline pressure is 10, the alveolar pressure is +10 like here. There is no gas flow happening. Fine. And when the inspiratory effort starts, say pleural pressure of -3, this alveolar pressure drops by 3. From 10 it becomes 7. Now there is a gradient. Okay, from 10 to 7 there is a gradient, and inspiratory flow will happen with much minimal work of breathing. That is the advantage you are giving by applying the external PEEP. In physiological condition or normal conditions, you have seen COPD patients pursing their lips. This is basically to create a positive end expiratory pressure so that the inspiratory flow starts with a lesser amount of work of breathing. Otherwise, they'll tire out and go in for respiratory failure. This is another diagram to understand that. Here we can see the alveolar pressure as +8, the pleural pressure is also +8, and the ambient pressure is 0, or the atmospheric pressure, and there is an airway collapse preventing the release of remaining part of alveolar gas into the atmosphere. This happens at the end of expiration. Now, beginning of inspiration, there is an inspiratory effort. The pleural pressure has become -8, and with lots of effort this alveolar pressure has come down to 0. Is there any inspiratory flow at this point? No flow happens because there is no gradient existing from the atmospheric pressure to the alveolar pressure. And now if you exert a little bit more, maybe if you can generate -1 alveolar pressure with additional effort, you can create a gradient and then the flow begins. So to begin the inspiratory flow itself, it requires a significant amount of work of breathing in case of auto-PEEP development. Now I am going to apply a +6 PEEP, extrinsic PEEP, to this system. You can see at the end of expiration, the alveolar pressure is 8, the outside pressure is +6, that is the end expiratory pressure is +6. Because of the alveolar, the airway collapse, there is no gas flow occurring. Now, beginning of inspiration with minimal effort, -2 pleural pressure, +8 becomes +6, and now there is a gradient from +6 to okay, sorry. Up to +6, there is no gradient and no inspiratory flow happens. And little bit more effort, it becomes +8, becomes +5. Now there is a gradient and then flow begins. So you don't need to have that much huge effort to begin the inspiratory flow when you have an extrinsic PEEP applied. Now the question is whether the PEEP is going to be helpful or counterproductive. We have all learned that application of PEEP will keep the airways open because of the positive end expiratory pressure. Does it happen like this? Will it obstruct the exhalation? For that concept, you can see this waterfall principle. In the previous example, the alveolar pressure was +10, critical pressure may be around +6, and the airway pressure of 0. And this is the waterfall happening. Now the application of PEEP will gradually elevate this baseline from 0 to +1, +2, +3, up to +6, up to something less than +6. This waterfall flow will keep on continuing. That means application of extrinsic PEEP less than the critical pressure is not going to affect the emptying at all. Instead, on the other hand, actually once this baseline is elevated, it helps the work of breathing for your next inspiratory effort. So in nutshell, when you diagnose possibility of auto-PEEP or intrinsic PEEP, you should apply external PEEP around 50 to 80% of the intrinsic PEEP so that the inspiratory flow, work of breathing will be significantly reduced. Here you can see the amount of flow over the waterfall remains constant until the level of in the stream below, that is the airway pressure, and reaches the height of waterfall. Like when the airway pressure reaches this height, up to this point, the flow will not be hampered. The release of the water flow will keep on happening. Whether it is from this pressure to this pressure or this pressure to here, it will keep on happening. There is no problem with the flow at all. But for the next inspiratory effort, it helps a lot. Okay, how do you estimate the intrinsic PEEP? First, if the patient is passive, you can reduce the PEEP to 0 before measuring auto-PEEP, and then you do an expiratory hold for few seconds, 1 or 2 seconds. Now you can see the baseline getting elevated. So whatever positive pressure measured at this point of time is caused by the dynamic hyperinflation or inadequate exhalation, and this is the intrinsic PEEP. Clear? So this can be done only on passive patients, and you reduce PEEP to 0 and then give expiratory hold. Whatever positive pressure you measure is auto-PEEP. Newer ventilators will calculate the total PEEP measured, and total PEEP minus applied PEEP also gives an idea regarding the possibility of inadequate exhalation. In clinically, how do you estimate? There will be missed trigger efforts. So clinically, you can just rely on unexplained tachycardia, hypotension, or clinical observation of active expiration or wheezes that continue to the onset of inspiration. The effects will be hemodynamic problems, increased work of breathing, and the trigger will have to cross the auto-PEEP level before inspiration is initiated. So the missed breaths will cause wasted breath. So this is what happens without auto-PEEP. From the baseline, -1 centimeter of water, if that is the trigger set, once it reaches -1, an assisted breath is initiated and the patient gets a breath. But here, there is an auto-PEEP developing almost, say, for example, 5 centimeters of water. There is a trigger, maybe much more than -1, but it is not touching the baseline. So that effort trigger is not getting answered. So after some time, patient again takes a deeper trigger, inspiratory effort. It goes to -1 below this new baseline. That means 5 plus 1, 6. Now the new trigger has become -6. So patient will have to give that much inspiratory effort to get an assisted breath. This is how auto-PEEP results in increased effective trigger value, and if the trigger is not reaching that level, it becomes wasted work. What are the factors affecting intrinsic PEEP? It will be minute ventilation, IE ratio, expiratory time constant. Again, I request my junior friends and residents to watch this explanation very carefully. You would think that if you want to wash out CO2, you increase the minute ventilation. That's what the majority of people do. Okay, for our patient, I have set assist volume control mode, FiO2 of 40%, tidal volume of 400, rate of 10, IE ratio of 1:2, PEEP of 5. I get an ABG done. ABG shows a pH of 7.28, PaO2 of 70, which is okay, PCO2 of 72, which looks slightly increased, no, not acceptable. So what to do? So my friend said, you go upon minute ventilation. Minute ventilation is tidal volume into rate. So increase the tidal volume to 500, increase the rate to 15 breaths per minute, and he leaves the case. 2 hours later, I did an ABG, which showed a pH worsening to 7.18, PCO2 also worsening to 82 from the initial 72. Now, how do we explain this change? We have increased the minute ventilation, but the PCO2 has increased. We'll take the first example. First case, we had a minute ventilation of 400 into 10 is 4000 ml. The respiratory rate was set as 10 breaths per minute. So one cycle time is 6 seconds. I have set an IE ratio of 1:2. So 2 seconds for inspiration, 4 seconds for exhalation, which means to exhale the 400 ml I pushed in with the IPPV, you are giving 4 seconds to come out. Okay. Now what happens when the minute ventilation was increased? Now in the second case, the minute ventilation is 500 into 15, that is 7.5 liters. The respiratory rate now is 15. So one cycle time is 60 by 50 is 4 seconds. 1:2 IE ratio, that means inspiratory time of 1.33 seconds and expiratory time of 2.66 seconds. So what's the change? In nutshell, we are giving 2.66 seconds for the pushed in 500 ml to come out. Initially, we were giving 4 seconds for 400 ml to come out, but now with the increased minute ventilation, the second set of setting, we are giving much lesser time for a higher volume to come out. That is why CO2 increases. So this is what happens. Initially 400 ml, 10 tidal volume, 1:2 IE ratio. The dead space was around 2 ml per kg. We gave 4 seconds for it to come out. If we just increase the respiratory rate, we are giving lesser time, 2.6 seconds for 400 ml to come out. But again, the physiological dead space has gone to 3 ml per kg. Again, the second setting, 500 ml tidal volume, 15 rate. You are giving 2.6 seconds for 500 ml to be exhaled, effectively increasing the dead space to 4 ml per kg. Again, you can see the capillaries are getting compressed. So pulmonary vascular resistance is increasing and core pulmonale will develop with this change. There is another example where I set again on volume control mode, FiO2 of 40%, tidal volume 420 ml, respiratory rate 15 breaths per minute, and I kept more expiratory time 1:3 and PEEP of 5. The peak pressure goes to 43. Again, I read on the monitor, the compliance is 50 ml per centimeters of water. Resistance is 30 centimeters of water per liter per second. Yesterday, I have mentioned regarding time constant. For adequate exhalation, you give at least 3 time constant duration for exhalation. Let's see whether our settings are okay with that concept. Here I have set a rate of 15 breaths per minute. That means one breath cycle is 4 seconds. I ratio 1:3 means expiratory time is 3 seconds. Now we'll see the time constant. We need 3 times the time constant at least as expiratory time. How do you get the time constant? Resistance into compliance. So 30 into, as mentioned, it's in liters. It has to be converted into liter. So it becomes 1.5 seconds time constant. So expiratory time should be 3 times 1.5, that is at least 4.5 seconds, which is not met with these settings. Do you agree? So what I'll do is, probably I'll keep the same tidal volume. I'll reduce the ventilatory rate to 12 and increase the I ratio further to 1:3.5. Again, the further titration will depend on the blood gas trend, or if you have an EtCO2, EtCO2 trend. Again, one more message is CO2 removal should not be happening in a matter of minutes to hours. You should give enough time for CO2 removal, because washing out CO2 from a level of maybe 106 to a perceived normal of 40 in 1 hour can have other implications. So the take-home message is CO2 removal is inversely proportional to the effective alveolar ventilation. Effective alveolar ventilation means minute ventilation minus dead space ventilation. To avoid dead space ventilation, you should give enough time for exhalation. So the settings would be tidal volume of around 6 to 7 mL per kg, rate of around 12 to 15. Low minute ventilation will definitely lead to slight rise in PCO2, which is the price we pay for preventing dynamic hyperinflation. In fact, the current literature suggests the risk of dynamic hyperinflation is much larger than those of permissive hypercapnia. So you target a normal pH, not a normal CO2. There are some factors which mention ventilation difficulties in COPD, because the disease may not have a reversible component. It's a progressively deteriorating condition. Quantifying dynamic hyperinflation at bedside is usually difficult. COPD patients are difficult to wean also. There will be other comorbidities and systemic effects. So the decision to intubate if the patient is not a candidate for NIV, non-invasive ventilation. Because of shortage of time, we won't be going into non-invasive ventilation. We have an excellent expert on NIV in our panel, Dr. Anoop. Anyway, we'll discuss invasive ventilation only now. Suppose the patient doesn't have a successful NIV trial, he will go in for invasive ventilation. So you have to be careful, because post-intubation ambu bag ventilation also should have low tidal volume and probably a low rate of around 6 to 7 per minute, which will do a lot of good for your COPD patient. You need to volume resuscitate the patient adequately before attempting induction, and probably you will need a small dose of inotrope or vasopressor in a core pulmonary patient. So if you are choosing volume control mode, control tidal volume will be, initial setting will be around 6 to 7 mL per kg, respiratory rate towards the lower range around 12 or so. I ratio with the more of expiratory time. Look at the P plateau and expiratory time constant. Reduce the inspiratory time as much as possible until the plateau pressure reaches 28 centimeters of water in extreme cases. You can use high flows. Maybe normally you will be setting around 40 to 60 liters per minute, but high flows in COPD patients will help you to deliver the volume with the minimum inspiratory time that we are giving to the ventilator. And extrinsic PEEP should be applied to counter the auto-PEEP. Around 50 to 80% of the intrinsic PEEP measured. That value is debatable because different authors give different values. And the patient is not passive, patient is taking spontaneous, you can switch over to PSV, pressure support ventilation mode. Again, you see for the volume whether it is adequate. Respiratory rate and IU ratio cannot be fixed by the operator, but you can again adjust the expiratory trigger sensitivity and rise time that we have already discussed. So management of auto-PEEP, low tidal volume, reduce the respiratory rate, increase the expiratory time, increase the peak flow, add extrinsic PEEP, good enough sedation, control of sepsis, bronchodilation, everything will help tackle the primary condition and minimize auto-PEEP. Regarding weaning, weaning begins when the precipitating factor of the respiratory failure is partially or totally reversed. There will be marginal respiratory mechanics because COPD is a tricky situation. Factors which increase the resistance like size of the tube, deposition of secretions in the tube, kinking or curvature of the tube, presence of elbow-shaped parts, HME in the circuit, everything should be taken care of. Because these patients are very likely to be on steroids and relaxant for a long time, you need to anticipate for myopathy. Role of tracheostomy in the weaning is debatable. The weaning can be done with pressure support mode or spontaneous breathing trial while on the mechanical ventilator. In very difficult cases, extubation onto NIV is definitely an option. Cor-pulmonale may warrant small dose of inotrope, a dose of diuretic, and low fluid strategy during the weaning. Okay, so these are the broad principles, and I have shown a few ventilator settings to tackle a case of COPD. I think my messages are delivered. If you have more doubts, we'll clarify during Q&A session. Okay, that's it from me for the time being. So I am winding up, and I request all the participants to attend the poll questions now. I think if you are viewing on full screen, you can reduce to normal view, and then I think the question is also there in the poll, but I'll read it out for you. The question number 1, what action you will take if the patient become agitated during SAT or SBT, spontaneous awakening trial or spontaneous breathing trial? Option A, heavily resedate. Option B, resedate to a RASS score of -3. Option C, titrate RASS -1 and return to previous ventilator settings. Continue with the spontaneous awakening trial or SBT, irrespective of the changes. So what action you will take if the patient become agitated during SAT or SBT? Option A, heavily resedate. Option B, resedate to a RASS of -3. Option C, titrate RASS -1 and return to previous ventilator settings. Option D, continue to spontaneous awakening trials or spontaneous breathing trials. Proceeding to second question, pick out the wrong statement. Okay, question is to pick out the wrong statement regarding COPD ventilator management. Option A, the disease may not have a reversible component. Option B, quantifying dynamic hyperinflation at bedside is very difficult. Option C, COPD patients are difficult to wean. Option D, the outcome is same as for acute asthma exacerbation management. Okay, I'll move to question number 3. Which of the following statement or statements are true regarding the management of auto-PEEP? Option A, low tidal volume, decrease the respiratory rate. Option B, increase the expiratory time. Option C, add or addition of extrinsic PEEP. Option D, all of the above. The answers will be discussed in the Q&A session following Dr. Anoop's lecture. It's over to Dr. Anoop. Thank you very much.
Thank you, Dr. Saneesh. Thanks for this wonderful presentation, taking through clinical application and the ventilator settings for conditions like COPD and other difficult to ventilate cases. So you made it so simple, and I hope that there is definitely a very useful information shared across. So thank you, sir. And now we invite Dr. Anoop Kumar to take over the session. Sir, I'm turning it to you. All yours, sir.
Thank you once again for joining us. And again, thanks for GE for making such a wonderful platform. Module 1 and 2, we had almost 1,300 participants. So today also we are having an excellent number. So thanks for joining us in this third module as well. So today, the weaning from mechanical ventilation, monitoring, case scenarios and COPD was discussed by Dr. Saneesh. So I'll be basically discussing ARDS management, the COVID management, and infection control practices in the COVID, related to the COVID-19. So to start with, we will go with the definition of ARDS. As you all are aware, we have changed the definition now following this Berlin definition of ARDS, where the timing should be an acute onset within 7 days after a non-clinical insult or a new worsening respiratory symptoms. And the edema should not be fully explained by cardiac failure or fluid overload, subjective assessment by echo. So echo should not show the cardiac failure features. And based on the oxygenation, last time we have discussed, based on the PF ratio, we can divide it into mild, moderate, and severe. And with the PEEP of equal to or more than 5, last time someone has asked. So PEEP this is a PEEP criteria. And the chest imaging should be bilateral opacities with more than 3 or 4 quadrants, not explained by other shadows. So this is the definition of ARDS. I'm not going into the too much the theory part of ARDS. And the physiological task in managing any ventilation, last time I've already told, carbon dioxide elimination, oxygenation, and assistance of respiratory muscles. But in ARDS, our main aim of ventilation is to maintain oxygenation by keeping these closed alveoli open and recruiting more and more closed alveoli. So that will be the our aim. And this was also discussed last time. Depending on the severity, like from mild to moderate ARDS, for all group we go with a low tidal volume of around 6 ml. The PEEP in the mild we use a very low PEEP, then a moderate PEEP of around 8 to 10, and severe ARDS we go with a high PEEP of 11 to 15, and more than 15 there is no evidence. Initially with mild ARDS we can try NIV or high flow nasal cannula, but with a severe ARDS we will have to prone ventilate, recruitment maneuver sometimes, and neuromuscular blockers. And severe ARDS, when the PF ratios are less than 50, we go with ECMO. And this was also discussed. We have, like when we are pushing the air inside, there will be a resistance offered. Then the alveoli will be recoiling, and the volume will be pushed back. And the volume placed in a closed space. When you place a volume into the closed space, it will increase the pressure. And in ARDS, we will be having a normal alveoli and a alveoli which are stiff. And the normal alveoli will not require higher pressure, but the stiff alveoli to open up will require more pressure. But when you apply the pressure, so the pressure will definitely move on to the area of less resistance. So there can be a chance of overinflation, and the volume change for a change in pressure, we call it as a compliance. So this term and concept should be very, very clear to understand COVID ventilation also. And what pressure we have to monitor, I've already told, we have P-peak, we were discussing in COPD, P-plateau we have, and we have having driving pressures as well. And in mechanical ventilation in ARDS, you should understand there are like in the ARDS length, we can have a normal length with like a reduced length volume where we have to use low tidal volume to protect that. So we will have to hypoventilate, and there will be carbon dioxide retention. The next part, we have to prevent the cyclical stretching by PEEP or prone by recruiting. And the consolidated length, we will have to require high pressure to open up, either by using recruitment maneuver or by using moderately high PEEP. And with the life-threatening refractory hypoxemia, we will have to sometimes open up these airways. So what is this recruitability? We have told last time, just refreshing those things. So when we put the patient on, say, volume control mode with 400 ml and 8 PEEP. So this is how it will be. It will be just opening up some of the alveoli. So now I'm increasing the PEEP. So herein when there are responders, like where with the higher PEEP, more alveoli will get recruited. So these group of persons are called responders, and the whole aim of ARDS ventilation is how much PEEP to be provided to open up these recruitable lung units. But at the same time, like if you are applying more pressure, there is a chance that these sometimes the small alveoli, the normal alveoli can burst and it will not recruit more alveoli, and these group of persons are called non-responders. So we should try to understand in ARDS ventilation who are the responders and what is the optimal PEEP and what are the other measures by which you can improve the oxygenation status. Okay, so here again you can see if you put a inspiratory hold like in responders, you can see here the plateau pressure was 30, driving pressure was 22. So here you can see the plateau pressure was decreasing, driving pressure is decreasing, at the same time the compliance is improving. So this is how you look, like if it is a responder, the driving pressure will drop and the compliance will improve. But if it is a non-responder with a PEEP increment, you can see the driving pressure will be shooting up and the compliance will be dropping down. Okay, so this is how you should approach an ARDS patient. And again, we have to use low tidal volume. We have to aim for a low plateau pressure less than 30, high PEEP to open up the lung, low driving pressures less than 15, low mechanical power, and reduce cumulative injurious strain. These last two, like because of lack of time, we are not making it complicated. And when you are applying the pressure, obviously the pressure will be utilized to distend the alveoli, and again it will be also used to move the chest wall. Okay, so when the chest wall is stiff, obviously you will have to use more pressure to expand the chest, and the pressure may be exerted to expand the chest, and the pressure, the alveoli are exposed. This what pressure here it is exposed is equivalent to the alveolar pressure minus pressure imposed by the chest wall. So this will be the our like the pleural pressure, or otherwise it is called as the transpulmonary. Sorry, otherwise it is called the from that pleural pressure we can actually derive what is transpulmonary pressure. So that will be the actual driving force. Okay, so the transpulmonary pressure is a plateau pressure minus pleural pressure. And the lung protective strategy in ARDS will be to keep plateau pressure less than 30, low tidal volume ventilation based on predicted body weight formula, which we have discussed last time. Male it is 50 plus 2.3 into 18 inches minus 60. In females it is 45.5 plus 2.3 into 18 inches minus 60. So, which with such low tidal volume deliberate hypoventilation, what change will be there? There will be carbon dioxide retention. Then again there can be other issues like the inspiratory pressure. You can see when you are applying the pressure, the driving pressure can change and the plateau pressure can also change. The plateau pressure can be determined by an inspiratory hold, which we have already discussed last time. And the maximum pressure exerted is the peak inspiratory pressure, which we have seen already during COPD ventilation. And with an inspiratory pause, we can see the plateau pressure, and the change between the plateau and the PEEP is called as a driving pressure. So this is a high PEEP resistance, and again we have the driving pressure, the plateau pressure, the difference which we have discussed. I'm not wasting much time here. Here again you can see the compliance or the driving pressure will be equivalent to the tidal volume divided by the static compliance. So here this again the concept should be very clear. Here in this one patient I am applying a PEEP of 5 and the total pressure is plateau pressure is 25. So the driving pressure in this patient is 20. So the same patient I am increasing the PEEP to 10. So the plateau pressure is now 30, but the driving pressure here is 20. Okay, so here the more lungs are recruited, but the driving pressure remains same. Okay, if sometimes if the recruitment is better, the driving pressure may dip down. So by increasing the PEEP along with the compliance everything, now we give more concentration on driving pressures. So you don't have to worry much about other pressures. Again, from 15 we are increasing. Now the plateau pressure is 35, but still the driving pressure is 20. Okay, our target for driving pressure is 15. I have already told, but this is just to make the concept very clear. With increasing PEEP and increasing plateau, you can have a constant driving pressure possible. Okay, so that concept should be clear. And how to see the driving pressure in a pressure control mode. So whatever pressure control over PEEP you are keeping, plus the PEEP. This is the total pressure control above the PEEP. So the plateau pressure will be the total pressure. So the plateau pressure here, it will be 12 plus 18 will be 30. And what will be the driving pressure? The pressure above the PEEP. So this will be the driving pressure. So here in a pressure control mode, you know what is the driving pressure, and you know what is the plateau driving pressure and the plateau pressure. So here again you can see the tidal volume divided by the driving pressure. So the compliance, the static compliance will be 25 centimeters of water. This is how we come to the calculation or the derivation of static compliance. So whereas in volume control mode, when we are putting a 450 ml tidal volume with a PEEP of 12, we will have to put the patient on an inspiratory hold to see what is the plateau pressure. Here you don't have to do that. Even without inspiratory hold itself, you will get to know what is the plateau pressure, the driving pressure, etc. This we have discussed last time, but just once again refreshing, the 15, less than 15 driving pressure by this amateur trial has showed a decrease in mortality. That is why we are trying to ventilate an ARDS patient with a driving pressure of less than 15. The assessment of recruitment can be done in different ways, either by the CT scan, which is a gold standard, impedance tomography, a PV tools, an esophageal balloon looking at pleural pressures, or like a best oxygenation or a best compliance PEEP. So today's class we will be discussing on the best compliance PEEP method, and the other option is looking at stress index, which we will not be discussing. There are other options like FRC, looking at best FRC, etc. The simplest way for PEEP titration is go with an arsenate PEEP table. There is a high PEEP table and a low PEEP table. The majority of the time we use with this low PEEP table, which we have discussed. So what is the recruitability? Now we have already told. So one patient from 8 to 12, when we are applying the PEEP, more alveoli will be recruited in a recruitable lung. But if it is a non-recruitable lung, even the baby lung will rupture, and obviously these patients will be having the worsening compliance. Here you can see the recruiters, the plateau pressures and compliance will be improving, but here it will be worsening. So here in this group of persons, from 8 PEEP, when we are increased to 12 PEEP, you can see the static compliance is increased from 19 to 25, and the driving pressure has dropped from 22 to 16. So now we want to know whether the 12 PEEP is enough or whether we want to give more PEEP. So I have increased from 12 to 14. So here when I am using a 14 PEEP, now the plateau pressures are 30, but the driving pressure from 16 to 16, it has gone up to 18, and the compliance is decreasing. So this is how you look at best compliance and best compliance. So from 18, the compliance is increased to 25 when you are increasing PEEP from 8 to 12. From 12 to 14, when you are increasing, you can see the plateau, the driving pressure, and the compliance is decreasing and driving pressure is going high. That means the optimal PEEP for this patient is 12 centimeters of water. The recruitment to do, the patient should be passive, deeply sedated. The paralysis is not always necessary. Patient should be hemodynamically stable, and the cuff should be slightly more inflated. We have discussed this also last time. 3 types of recruitment. You can give it a sustained inflation, or like an incremental PEEP. Gradually you increase the PEEP to like reaching up to 40, hold it for 30 to 40 seconds, then gradually titrate down. Or simple terms, we can control ventilate with 20 PEEP and 20 centimeters of pressure above the PEEP. So total 40 centimeter for 40 seconds. So this method we will be discussing in detail. Okay. So these are the once like you recruit, you should know what is the optimal PEEP and how to titrate. So these were the points which we were discussing last time. So now coming to the ARDS ventilator settings once again. So how we will start? Any patient when they are hypoxic, you start the ventilation with 100%. But at the same time, you should be aware, you should try to reduce it to the non-toxic level of oxygen, which is 60%. So even when with the 100% or a 80%, your patient is saturating more than 90%, that patient is very, very sick. And somehow with all ventilatory modification, you should try to reduce the FiO2 to 60%. And the tidal volume, always you have to try to keep it around 4 to 6 ml, and the plateau pressure, try to keep it less than 30, and driving pressure less than 25. The PEEP setting I've already told, which we will discuss in detail. So PEEP should be set in such a way that we should try to reduce the driving pressure to less than 15, for a plateau pressure somewhere around 20, 28 to 30. And you have to adjust the pH to keep more than 7.25. How we can do that? You increase the respiratory rate. And PCO2, it is always not necessary you have to keep it less than 50. You don't have to worry much about the PCO2 values. And the tidal volume, depending on different groups, like in majority of the groups, you can keep it somewhere around 4 to 6 ml. And PEEP in mild group, we keep it at around 5 to 8, moderate 8 to 12, and in severe 12 to 16. So now we will see these things we have learned last time also. Now see with these things how we are going to ventilate the patient. So I have a patient with severe ARDS. Okay. So now like I ventilated, I want to recruit this patient. So what I am going to do? See, this patient is holding on with a 50% FiO2. So I kept the FiO2 at 50 itself. I kept the pressure control, and the control I kept at 20. PEEP at 20, and it is a assist pressure control, or PC, or an assist pressure control mode. And then like I am ventilating it for 40 seconds. So 40 pressure for 40 seconds. Here again you can keep an IE ratio of 1:1. This is for 30 to 40 seconds. So after that what we do? This is the problem. So now we have already recruited. The saturation is improving. So what to do now? So now you know the compliance here is 20, like tidal volume by driving pressure. So here again the plateau pressure, as you know, the plateau pressure is 40, and the driving pressure, the difference is 20. So now we know that driving pressure is high, the plateau pressure is also high. We are trying to open up maximum alveoli. Now what we can do? So now the driving pressure we want is 15. So what you have to do? The pressure control you reduce to 15. So now your driving pressure will be 15. The PEEP, you want to see what is the optimal PEEP. So once the lungs are completely open up, you can try something like a downward titration of PEEP. So now from 20, I have reduced my PEEP to 16. So what should I know? Whether the 20 PEEP is better or 16 PEEP is better. How will I know? I just put an inspiratory hold. I just measured the plateau. Now see the plateau pressures are coming down, and see the compliance. From the 20, the compliance has improved to 24. Okay. At the same time, you have to see whether you are getting an adequate tidal volume also, because this is in the pressure control. Okay. Now I have reduced the PEEP to 16. Now I am getting a compliance of 24. Still, I don't know whether this is the optimal setting, because the compliance is 24. Sometimes this PEEP may not be required. So I will again reduce the PEEP to 2 again. So now in the same pressure control, same FiO2, I have reduced from 16 to 14. So now again with the inspiratory hold, you see what is happening to the compliance. Now the compliance is again slightly improving. So how will you know? The driving pressure is constant here, because you are ventilating with a pressure control. So whatever pressure control you are keeping above PEEP will be the driving pressure. So you have complete control of driving pressure here. So the driving pressure here again 15, but the compliance is improving here, and the plateau pressures are also improving here. Obviously that will be reflected by improving tidal volume. Last time someone was asking how much time you have to wait between like the changes. Again, there is nothing like a fixed time. You can give it somewhere around 5 to 10 minutes and wait what changes is happening. So now I don't know whether the 14 is adequate, so I am changing to 12. So when I am changing the P from 14 to 12, again you can see my plateau pressure is dipping, the compliance is improving, and obviously the tidal volume also has to improve. Okay. So now with the reduction in PEEP also I am having an improvement in compliance. So the patient does not require 20, 16 or 14 PEEP. With the 12 PEEP, the patient is having better compliance than the previous higher values. So I have to again down titrate and see. Now again with the same setting, I have reduced the PEEP to 10. I have measured the compliance. So here you see now the compliance is dipping. That means what does it indicate? So the patient best PEEP here is based on the compliance, it is 12. I've already told there are many methods for PEEP titration. This is a one simple bedside method by which you can titrate PEEP for ARDS. Okay, this is I've already told, this is a 3 sessions only. We have so many topics to cover. So at least this basic concept, if you understand, you can ventilate a severe ARDS patient. So I think that concept is very, very clear. This is called the decremental titration of PEEP. So you recruit with a high PEEP, gradually reduce the PEEP values and see at what PEEP the patient is having a best compliance. Now you are in a pressure controlled decremental PEEP titration. Now we again go with like you can see, I have again recruited the patient, FiO2 50, pressure control, PEEP 20. Now I am seeing the patient with a volume control mode. How to titrate the PEEP in a volume control mode? So majority of the trials are done in a volume control mode. So here I have calculated, and with the predicted body weight, I have calculated around 6 ml, and it is coming 350 ml. So from 16 I have reduced the PEEP to, sorry, 20 I have reduced the PEEP to 16. I have put it in an inspiratory hold, and now my driving pressure is almost same. The compliance is 24, the plateau is 36. So here two things you cannot accept now. The driving pressure is high, more than 15. The plateau pressure is also more than 30. So you cannot accept this much secretion, this much settings. So now again you try to reduce these values by reducing the PEEP. So from 16 you are again reduce the PEEP to 15. 14 you keep the tidal volume constant and see what is happening to the driving pressure. So at 14 you can see the driving pressure is again dropping to 18. The compliance is actually slightly improving. The plateau pressure is dipping. Now you are at a 14 PEEP. The same thing we are repeating. This is in the volume control mode. Last time what we did, the same thing. Now again I am dropping the PEEP to 12. I am putting it in inspiratory hold. See the plateau pressure. Now it is again dipping. Driving pressure is reaching at the target. Now it is at 15. The compliance is improving. So now this driving pressure is at an acceptable level. Plateau is also at an acceptable level. Compliance is also improving. But we will see if I drop the PEEP again, whether the compliance is going to improve. I am again dropping the PEEP to 10. Keeping the, this is volume control 350 ml. Sorry for this mistake. Volume control 350 ml. So here you can see in the inspiratory hold I am getting a plateau of almost same, but again you can see the compliance is decreasing and the driving pressure is increasing. That means here this is the ideal PEEP for the patient. So now again a volume control mode with a decremental PEEP, a tidal volume of 6 ml per kg. This is how you titrate for the PEEP. Now you see the next patient. Like I am having a patient, I am like an ARDS patient. I am just ventilating the patient. Patient is extremely hypoxic. That is why after intubation I put the patient on FiO2 100%, tidal volume of 400, slightly high PEEP 7. Then I measured the inspiratory hold. So I am getting like a plateau pressure of 36. Driving pressure is very high. Compliance is 25. And IA ratio I kept it 1.2 and respiratory rate is 18. So I have already told, if you are going for an ABG, you have to always mention what is the FiO2, what is the PEEP, what is the ventilatory tidal volume and respiratory rate. So, or you can write the minute ventilation. Here the minute ventilation will be 400 into 18. That will be the minute ventilation. Tidal volume times respiratory rate. This will have to take it as 0.4 into 18. Okay. So I did a monitoring. So the monitoring now showing a SpO2 of 92%. And my ABG is showing 7.3 pH, PO2 of 80, PCO2 of 38. Are you happy with this thing? Are you happy? You are happy having a saturation of 92. Last time itself we have discussed, we have to look at PF ratio. So the PF ratio here is, you are having a 100% saturation and so the PaO2 is 80. So 80 by 1. So you are having a PF ratio of 80 where you are in a severe ARDS group. And now you are in a high FiO2 in a toxic limit. So somehow you have to reduce the FiO2. So what we can do to reduce the FiO2? again we will have to open up more airways. So what can I do? Like I have again, see now the plateau pressure, my aim is to reduce the driving pressure and reduce the plateau pressure. So obviously I will have to reduce the tidal volume. And as the saturation is slightly high, I am slightly reducing the FiO2. PEEP from 7 I am increasing to 10. Now with the inspiratory hold, my plateau pressures are dipping, driving pressures are dipping, compliance is not having a much change. And to improve the oxygenation in an ARDS, you have to give always more inspiratory time. So from 1:2, I made it to 1:1.5. And as I am reducing the respiratory rate to keep the minute ventilation and to keep the CO2 keep the CO2 within the almost normal limit, I have to increase the respiratory rate also. So I increase the respiratory rate. Okay. Now see, my SpO2 is slightly better as I am increasing the PEEP. At 80%, I am getting 94%. The pH, even though the PCO2 is 54, but my pH is maintained, I am not worried about that. And the PF ratio also, like you can see, the PaO2 by FiO2 will be somewhere around 82 by 0.8 will be more than 100. It is improving. So now again I will see, like I have to see, I still am at 80%. So I have to still improve the oxygenation. So now I have increased the PEEP to 12, and obviously as the saturation was improving, I have reduced the FiO2 to the target level of 60%. Now with an inspiratory hold, I have measured the plateau pressure. It is 15. The driving pressure is 15, and the compliance is also improving. Now I am in a target driving pressure. What other change I can make? Like I can make an IE ratio of 1:1, and I can slightly increase the respiratory rate if required if the pH is dropping. Here actually the pH was not dropping. So the pH is this with this pH I don't have to change, but there was another ABG. So where I was it was showing a dip in the pH. That is why I've increased the rate. So with 30 rate now I'm able to maintain a pH of 7.2. But you can see the PCO2 is still at 62. So friends, please keep in mind, you don't have to look at PCO2 and increase the respiratory rate or tidal volume. You can accept this CO2, that is the permissive hypercapnia, which we have already discussed. You just look at the pH and try to keep it more than 7.15 to 7.2. And now you have increased the PEEP to 12. Still, and again IE ratio you have to keep, and in a severe hypoxemia 1:1, respiratory rate you can go up to 35 to maintain the pH. So now again I am increasing the PEEP. I don't know whether this PEEP is enough. So this is called the incremental titration. Last time we were doing the decremental. So now after ventilating I am slightly increasing. So from 12 I have increased the PEEP to 14. So the plateau pressures are going high. The driving pressures are also going high. The compliance is not. The compliance is also dipping. So this means the patient does not require 14 PEEP. The 12 PEEP is having a better recruitment. Okay. This is how you do an incremental titration of PEEP. This is like after an intubation of an ARDS patient, how I have changed the PEEP and how I have monitored the driving pressure and compliance. What other changes in IE ratio I made, how I changed the respiratory rate for a target pH. So this is how we change the settings. Here we don't have to worry, because as the compliance start dipping, you don't have to further increase and see it is like this is again the compliance is again dipping. You don't have to worry. But here you can see if you are again increasing, that will further reduce the plateau, further reduce the compliance. Okay. So once you see that the compliance is dipping, you have to stop at that point and come back to the previous value. You don't have to again recruit more and see whether it is improving. This is how you do the incremental PEEP titration. Now, I think you understood what is the ARDS ventilation concept. So now with this knowledge of ARDS ventilation, now we move on to the COVID ventilation. So before starting COVID ventilation, we all should have a basic concept about COVID-19 and how to use the drugs. So I've seen many clinicians doing mistake. That is why I am starting with this slide. So you can see initially like up to almost 10 days there is a peaking of viremia, and that gradually by about 10th day the viremia settles down. it will again, by 10th day, the patient won't be viremic, patient won't be able to transmit the disease, and that viremia will settle down. And even if you do a PCR at this point of time, PCR may show positivity. That means that is only some fragmented the viral particles. The patient will not be infected. Regarding the oxygen saturation, the patient will be a normal oxygen saturation up to about even 10 days. Later on, the patient can develop inflammation, which is called as an early pulmonary phase, and can develop hypoxemia. So this is also very, very important, like especially the patients with comorbidities and patients with high CRP, D-dimer values, etc. These patients, even though their oxygen saturation remains same up to 7-8 days, they can further deteriorate afterwards. So a patient remaining remaining in normal oxygenation does not mean that that patient will be in the stable stage. They can go into early pulmonary phase and develop complication. That is why you have to watch such patients for at least 14 days. Then coming to the inflammatory response. Initial 5 to 7 days, you won't get an inflammatory response. But later on, after the end of 1 week, the patient will develop inflammatory response by the time the viremia will settle down. So here, at this point, you have to start the inflammatory therapy. Now coming to the treatment part. So in the viremic phase, when the viral load is high, so this is the phase where you will have to start antivirals. And with the available evidences, the remdesivir is the antiviral drug with a reasonably good evidence. So if the patient is having a persistent fever or likely to deteriorate because of these symptoms, etc., you start the patient on remdesivir at this point. Suppose your patient is becoming hypoxemic by about 10th day. Okay, the patient is desaturating. See, by this time, your viremia has completely cleared. You have already closed after 10 days. So there is no point in giving an antiviral drug after 10 days. This concept should be very, very clear. I've seen many clinicians doing the mistake starting an antiviral drug after 10 days. So that is because that clinician is not having the basic concept of the disease. Now coming to the inflammatory phase. So there is an early inflammatory phase where the patient will be having a dip in saturation, and the mild oxygen requirement will go into a high oxygen requirement. Patient will become tachypnic, and you will have to start the patient either on high flow nasal cannula or NIV. So those are the group of patients who are going to benefit with dexamethasone based on the recovery trial. So even if the patient is having a mild hypoxemia requiring oxygen, you don't require a dexamethasone for that patient. We don't have enough evidence for such group. A patient who is requiring NIV, HFNC or high flow oxygen, definitely you have to start the patient on steroid. The same way those patients who are ventilated also, they will benefit from steroid. If this patient is again going for the severe inflammatory response where your ferritin values are going high, LDH is going high, patient is having persistent temperature, interleukin levels are high, you do something like an H score and see the score is more than 150 or 169. So these are the group of patients where you will have to start the other like immunomodulatory drugs like tocilizumab. So I think now this concept is very, very clear. Okay. So this is how we treat the patient with COVID-19. Now coming to the oxygenation part. So if the patient is having a PF ratio of less than 150 and hypoxemic, there is no doubt you have to mechanically ventilate the patient and go with the lung protective strategies. If that oxygenation is mildly, in the PF ratio more than 150, you start the patient on NIV or an HFNC. Then you can monitor these persons and see whether these persons are deteriorating. And if showing that, if they are showing a deteriorating trend, immediately you have to intubate the patient. So here, how will we optimize the patient on NIV? So NIV, as you know, we have an IPAP and an EPAP. So here in this patient, you can see a huge tidal volume. So there will be an overstretching of lungs because of this like a significant respiratory effort. So this patient, if you connect into the into the NIV, you can see they'll be generating huge tidal volume, more than 700 or 800. So this will cause an overstretching of lung fields, and that will produce something called a PCLI, or a patient-induced self-inflicted lung injury. Okay, so you have to prevent that overstretching. What we can do, you increase the EPAP. So once you increase the EPAP, your tidal volume will reduce, and again the IPAP you have to keep it in the minimum level. You don't have to give more IPAP when the patient is having a significant respiratory drive. This is how you start the patient on a NIV. Now, suppose if the patient is requiring a high oxygen requirement, not comfortable with normal oxygen, then you can start. Other option is high flow nasal cannula, where you can give a high FiO2 up to 100% of humidified oxygen. Here you will be setting the temperature, the FiO2 you can set by adjusting the flow of oxygen, and again the flow in the machine. So the flow in the machine, especially when you need a PEEP effect, you have to keep somewhere more than 40. So 40 to 60 liters flow you have to keep. FiO2 you titrate based on the respiratory, the oxygenation requirement. So now you have started patient either on HFNO or NIV. So now you should understand whether these patients are responding to NIV or HFNC. From this point onwards, you should be very, very clear. And I think this is the area where majority of us are doing mistake. So what we will do, we will keep the patient on NIV or HFNC. We will gradually increase the FiO2 to 80, 90, 100, etc. Or like in NIV, we keep the oxygen, the maximum flow possible. The patient may be breathing at 30, 35, 40 respiratory rate. The saturation will be 90, 91. You are happy because the patient's saturation is 90. But you are not looking at how much oxygen you are giving. And once you keep this patient on such a fluctuating tidal volume and high respiratory rate, they are going to develop severe self-inflicted lung injury. And once that damage has occurred, definitely you won't be able to rescue that patient. So, dear friends, please understand that the patient on NIV or HFNC, you should understand at what point you have to stop these and you have to ventilate that patient. If you are delaying ventilation in that group of patients, you may not be able to rescue those patients. Even the patients who are dying in my unit, like those who are referred from outside, majority of the time this is the issue. When we get a phone call, they say that the patient is stable on NIV, saturating at 92%. Yesterday also I had a phone call. So I told I want to know the details. So those people don't even know how much FiO2 they are keeping. So when I asked, the FiO2 was almost 90%. He is saturating at 92. Then I asked for an ABG. ABG was showing his CO2 values of 18 and the pH of 7.6. What does it mean? The patient has already gone for an alkalosis, respiratory alkalosis. Why? He is severely tachypneic. You can see from that ABG itself. So such group of patients, then I asked, so they told like 5 days like he is like that. Then when we shift that patient, we can see extensive lung damage. Whatever treatment you give to such patients, it is very, very difficult to rescue those patients. So please don't unnecessarily prolong intubation and keep your patients on NIV. So now coming to the NIV tolerability, how will you see? The patients on NIV, HFNC or high oxygen, how to assess that patient? So this is based on this ROCA's paper. We call it as a ROCA index. So the ROCA index is, ROX index it is called by the ROCA. So this is the ratio of SpO2 you divided by the FiO2 to the respiratory rate. So if it is less than 5, that means the patient is deteriorating. You have to assess this index every 2 hourly and see whether this patient is tolerating or not. If ROX index is more than 5, you can comfortably keep this patient on NIV or HFNC or oxygen. If it is ROX index is less than 5, immediately you have to think about ventilating such patients. Now, I've already told this patient I put on HFNC. Now the patient is on FiO2 of 50. SpO2 is 94%. Respiratory rate is 20. So how will you calculate ROX index? So ROX index is SpO2 divided by FiO2. So 94 divided by 50 FiO2 means 0.5 divided by respiratory rate 20. So 9.4. So now the ROX index is 9.4. And you see subsequently what is the ROX index. So if the ROX index is slightly going up, that means the patient is improving. The same patient I can see another patient I am putting on nasal oxygen. The patient is on 3 liters per minute of, this is minute, So patient is on 3 liters per minute of oxygen. So how will I calculate the FiO2? FiO2 will be 21 plus 3 into 4, because every 1 liter you have to add 4% from the baseline room air FiO2 of 21. So for 3 liters, 3 into 4. So total will be 33%. Patient is saturating at 94. The respiratory rate is now 30. So now you have to see what is the SpO2, 94 divided by 0.33, and again divided by the respiratory rate 30. So it is ROX index is 9.5. You see these both patients are equally sick now. The patient on 3 liters per minute, but his respiratory rate is very high and his saturation is low. So that is why his ROX index is 9.5. This patient on FiO2 50 is also maintaining a ROX index of 9.4. So the severity wise both are almost equal. Okay. Now another method of the like assessing the tolerability of HFNC and NIV is looking at work of breathing index. Here you can see respiratory rate by counting. You can see less than 21, 21 to 25 2, 26 to 33, and more than 34. If there is a nasal flaring during inspiration, as is shown in this picture, it is given 1 point. If the neck muscles, sternocleidomastoids, are in use during inspiration by palpation, you can give 1 point. And abdominal muscles are in use during expiration, you can see by palpation, it can be given 1 point. So if this work of breathing index is more than 4, that also indicates that the patient is not tolerating your therapy. Or in simple words, if the patient is extremely tachypneic on oxygen or NIV or HFNC, either you have to modify the settings of these devices. If on an HFNC, you will have to increase the flow from 40 to 60. If it is on an NIV, you have to try increasing the EPAP and see whether the patient is tolerating. Here at least 2 hours you have to wait and see whether what is the difference, like 2 hours, 4 hours, 6 hours, like that. You have to see the ROX index or work of breathing index. Okay. If it is tolerating, you can continue. Otherwise, you will have to think about intubating the patient. So now see this diagram. This is the basically you can see the first diagram is with the spontaneous breathing, the lung expansion, and this is with the controlled breathing, different phases of respiration. You see with the spontaneous breathing how much overstretching is happening to the lungs. So once this overstretching and cilia has damaged the lung parenchyma, it will be very, very difficult to rescue such patients. So even when you control ventilate, you can see this is the patient with mechanical ventilation and spontaneous ventilation. See, these red areas are indicating the volumetric strain. So on spontaneous breathing patients, you can see how much strain it is happening, but in controlled ventilation, the strain will be less. So you need timely intubation. So that is the first concept. You should be very, very clear as far as the COVID ventilation is concerned. Don't think that if you delay the intubation, the patient is going to survive. No, patient will not survive. So that point should be clear. And there are many data also, like the relative risk of death in the hospital increases as you are delaying the intubation in a nasal high flow nasal cannula. The high flow nasal cannula failed. You can see the time as you increase, the risk of hospital death is also more. Now you have decided your ROX index is down, your patient is in an isolation room, if possible in a negative pressure room. You have decided to ventilate this patient. So how you are going to ventilate? You put the patient in a negative pressure isolation room if possible. Keep the monitor on one side. Your airway equipment like your tubes, the bougie, all things you keep in the other side. The person who is going to intubate should be here. You can keep the ventilator also here. Then the drugs monitor, etc., other monitors you keep it here. And the person, this is the person who is going to monitor the ventilator and the monitor, and he is the person who is going to give you the drug. And this is the person who is going to give you the equipments, airway equipments, and required pressure if required. So in an intubating room, you need only 3 persons and everything should be ready. And if the patient is like, you can either put the patient initially on NIV on ventilator itself and pre-oxygenate with the ventilator, or if the patient is on a high flow nasal cannula, you can use that itself, and then without pre-oxygenation you can go for a intubation. The skilled intubator or experienced intubator should always do that. If possible, do a video laryngoscope. And again, if that you can, if the intubating the hood, if you want, you can use that also. Outside the room, you need a runner. This is the person who is going to get you the equipments or like any drugs if it is required. So this is how you have to place the patient. You have to place the 3 persons inside, how to assist that. Now see how you are going to modify your ambu bag. So I've already told like you have to do the modification in NIV circuit, HFNC, and in ventilators and ambu bag to reduce the aerosol generation. Here, what you have to can understand is you are when you are ventilating the patient, there is an expiratory part here where you are keeping a PEEP valve also. So before this expiratory part or between the patient and the expiratory part, you have to keep a viral filter. So whatever the expiratory air is coming, that will be coming after filtering into the viral filter. This is how you have to keep an ambu bag. Now, one more thing you should be very, very clear before going into the COVID ventilation. What is compliance? A patient with a high compliance means this is a very thin, a flyable lung which is easily distensible. Okay, very easy to distend. So this group of patients with high compliance will be having a low elastic recoil, or this is called as a low elastance group. Okay, high compliance will be having a low elastance, or the compliance and elastance are inversely proportional. So this is a stiff lung where the patient will be having a low compliance but high elastic recoil. So this group will be having a high elastance. Okay, so this is a patient with a normal compliance and a reduced compliance. And the compliance is basically a distensible lung will be very compliant and a stiff lung will be less compliant. Okay, I think that concept about ARDS is very clear. Now we will move on to the COVID ARDS. So we have 2 variants described by Gattinoni. One is called the type 1 variant, otherwise it is called an L type, and a type 2 variant, otherwise called as an H variant. Here you can see the lung fields will be almost normal. There will be slightly patchy consolidations. Here at this point, you can see there is like a significant consolidation looking like our normal ARDS. One more point I wanted to add at this point. So this week I got at least 6 references, like a young patients who are completely normal. The clinician wanted to assess his lungs and they are taking a CT for that lung. And asymptomatic patients, CT. So majority of the COVID patients, even if they are completely normal, if you do a CT, you can see some of these peripheral shadows. That doesn't mean that the patient is sick or the patient is going to develop a severe lung changes and you have to bombard him with all antiviral steroids, everything. I have already told the steroid evidence is for a significant hypoxemic patients on mechanical ventilation, NIV or HFNC, not for non-hypoxemic patients. And hypoxia means your saturation should be less than 94% at least, or 92%. Okay, if the saturation is somewhere around 95, 96, don't assume it is low and start steroid. Please don't do that. Steroids are having so many other issues also. So don't think that all COVID patients should receive steroid. So this is the type 1 lung. So here, what is the difference? These patients with a normal lung fields will be having a high compliance, but as we have told, they will be having a low elastance. So this low elastance, this is called as L group. So they also will require, they also will be having low ventilation perfusion ratio, low lung weight and low recruitability. These group of patients are not recruitable. Now we have other group of patients. These are just like any other ARDS. They will be having a low compliance but high elastance, high left to right shunt, again high right to left shunt, and again high lung weight and high recruitability. So this group of patients will require high PEEP, and this group of patients will not require high PEEP, and you can manage the hypoxemia with high FiO2. How we are going to do that? I've already told. This is the one patient we have, basically this is like a normal patient. developing like ARDS. So usually there can be hypoxic pulmonary vasoconstriction. That will not happen, and there will be microthrombate to the vasculature, and there can be high shunt, and they will be developing hypoxemia. Okay, so these are the patients who are not responding to PEEP or recruitment with normal compliance. So their alveoli is absolutely normal, as you can see. The problem is with their vasculature. But there are other group of patients where they are having the flooding of their alveoli like any other ARDS. So they are the group with low compliance, high elastance, so-called H group, who are going to respond to high PEEP, prone position, etc. Okay, and a high respiratory rate can be because of hypoxemia, an increased metabolic demand and cytokine storm, and neurotropism. Why that is important? Whenever you are assessing ROX index also, you see whether the respiratory rate is more because of like a fever or a cytokine storm or a secondary infection, etc. Those parameters you can definitely control, and you can give some more time for those patients for initiating intubation. So now the evolution of the disease. I've already told we will be having a type L patient with a high compliance. So they may sometimes remain unchanged for a period. Then they can gradually improve, or sometimes they can go worsen also. This L group of patients can develop multiple lung shadows and can deteriorate. This is basically because of patient self-inflicted lung injury. So this L group of patients also, when you are ventilating, you should try to avoid this patient self-inflicted lung injury. So that can again produce lung edema, dependent atelectasis, the increasing lung weight, injury attributable to high stress ventilation, more evolution of COVID-19 pneumonia and NH pneumonia. Okay, so the change from L to H is possible. The severity can change. Now, this is a very, very important slide. So people are getting confused between H and L type and how to keep an FiO2 and PEEP. Which group you have to give more PEEP, and which group you have to keep in a normal PEEP. Suppose you forget about CT finding everything. I have an ARDS patient. I've started on, I have a COVID patient developing hypoxemia. I started the patient on HFNC, put on optimal settings. Now the ROX values are coming down to almost 4 or 4.5, less than 5. I've even tried NIV, keeping high EPAP, all optimal settings. Still the ROX values are less than 5. I've decided to intubate the patient. I've intubated the patient. I put the patient on volume control mode. I put the patient on 100% FiO2. Tidal volume I kept it 400, PEEP at 7. So what I have to do next? I have to see what is the driving pressure and what is the compliance. I have put the patient on inspiratory hold. So my plateau pressures are high. Now the compliance is very low and the driving pressure is high. Okay, look at here. The driving pressure is high, the compliance is low, the plateau pressure is very high for a normal tidal volume. So what does it mean? So this is a patient who is going to respond for a incremental PEEP, because here the driving pressure is high, the compliance is low. So this is a recruitable lung. So you forget about HL, everything. So only thing, if the plateau pressures are high, you have to look for the compliance, and if the compliance is low, you have to titrate the PEEP. And this is the so-called, which group of patient it will be? Low compliance means it is high elastance. So this is a H group. Okay. So forget about H group, all those things. So here you have to definitely increase the PEEP. Now coming to I've kept other settings at I ratio 1:2, respiratory rate 18, etc. Okay. So this is now almost the patient will be having a severe ARDS like picture, your low compliance or high elastance H group. Now this is a type H with low compliance. Now I have another patient, the same, not tolerating HFNC, NIV. I ventilated, same settings. I put at FiO2 100, tidal volume 14 and PEEP at 7. So here I am doing an inspiratory hold. I am seeing a very low plateau pressure, 24. Driving pressure is extremely low and the compliance is very good. So this is a very good compliant lung with a very low driving pressure. So this group of patients are not going to improve with a higher PEEP. So here, this group of patients, when you are ventilating, you can accept them like a reasonably good tidal volume, and again you can accept high FiO2 levels. Don't try to like target a FiO2 of 60 in this patient. You can keep titrating an FiO2 for a saturation of somewhere around 90-92, but not more than 92. So try to keep it a minimum FiO2, but don't try to recruit this patient. So this patient, what will I do? Like, this is the patient with type L and high compliance. Okay, so here there is no role for increasing PEEP. You keep it at whatever PEEP, 5 to 7, like a 6 to 7 ml tidal volume. Here again you have to see whether the patient is not hyperventilating. If the patient is having hyperventilation and high tidal volume, obviously you have to keep more PEEP, as I have already shown in non-invasive NIV diagram. Other option, everybody is thinking, like if you want to reduce the respiratory drive and to control ventilate, you have to always paralyze and ventilate. Not true always. You don't have to paralyze always. Instead, you can use high dose of opioid and benzodiazepine in such group of patients. Suppose this group, this patient, what I am going to do. So here, as I want to do, I have already told, I can keep the patient at PEEP 7. I can look at FiO2. If 90 is required, I keep at FiO2 of 19. I may not require this much high respiratory rate. I can still reduce the respiratory rate. But this group of patients, what I will do, from 7, I try to increase the PEEP to 10. I reduce the tidal volume to 350 to reduce the plateau pressure. Here now you can see the plateau pressure is reducing, but driving pressure is still high. The compliance is not changing. So I have again increased the PEEP to 12. Now the plateau pressure is less than 27. Driving pressure is almost reaching 15. And I'm keeping an I ratio of 1:1 to improve the oxygenation. I'm increasing the respiratory rate also. So this is a group of patients who you have to manage like any other ARDS patient. But when the plateau pressures and the driving pressures are low, this is the group of patients who is having issues with the perfusion. Their lung parenchyma and compliance is almost normal. You should not use very high PEEP in this patient. That will damage their lung again. Okay, so these are the basic concept of COVID ventilation. You forget about HL and all, just ventilate normally, see what is the driving pressure, plateau pressure. If the plateau pressure are high, obviously they will be PEEP responders. You have to use PEEP. If your plateau pressures are normal with normal driving pressure, you cannot recruit those patients. Don't go for a high PEEP, use a 5 to 7 PEEP. And high FiO2 is acceptable in this group of patients. But again, even if you start with this group of patients, gradually they can also worsen into like a low compliant lung. Here, like when you are optimizing, which we have already discussed, how to optimize the PEEP, how to optimize I ratio, everything we have discussed, you go with that. Okay, just like in normal ARDS. Here again, don't think about ventilator-induced lung injury, other stress factors and respiratory rate. Look at pH and decide respiratory rate. Forget about PCO2. You can accept high PCO2 values. Now, this is again another excellent review in the current opinion in critical care. So, this is like they were looking at spontaneous effort at lower PEEP and higher PEEP. Here you can see the pleural pressure swing is -20 at a lesser PEEP, but with a higher PEEP, that pleural swing can be reduced, so the inflammation also will be less. So when you are weaning and when you see that the pleural pressure swing or the tidal volume variation is too high, you can put that patients on higher PEEP and you can reduce this fluctuation. Same is applicable in NIV also. You can use the patient on high EPAP. Okay, so the PEEP can also reduce spontaneous effort and can reduce self-inflicted lung injury. You don't have to paralyze your patient always. What are the other changes you are going to make in a ventilator? Like heated humidifier, try to avoid that. Even if you are using a heated humidifier, like you have to use a heated circuit with the heated wires in the circuit. Other than that, the normal humidifiers should not be used. You have to always use a closed suction, otherwise the chances of aerosol generation will be high. You should never use a nebulization in a COVID patient or a COVID suspected patient. Nowadays in our ICU, we stop nebulization for all patients because as you know, even after a PCR is negative, at any time they can become positive or you may be missing one case. So you have to always use a MDI adapter, and using an MDI adapter, you can use these meter dose inhalers instead of nebulization. And the spacers we cannot use with the ventilator circuit, but there are different devices. This is called as the devices which can be connected to the ventilator circuit, MDI adapters. Different types of MDI adapters are there. So you start using an MDI adapter to your ventilatory circuit, and you have to always place a viral filter also. Where you will place a viral filter. One thing at the at the Y port you can keep a viral filter, and again at the expiratory port also. So 2 viral filters should be placed for all patients, or an HME filter is also good enough at patient end and one at expiratory port. Okay, so no closed section, no open section, no normal humidifiers, no nebulizers for COVID patients. Now coming towards the end of our session, what are the infection control practices we usually adopt? So here the infection control practices for ventilators are: you have to always use a single patient use circuit. Reusable circuits are not at all advisable for COVID patients. I know nowadays we are not using that. And again, we don't have to unnecessarily change the circuit. Only if it is severely soiled, you have to change that. Otherwise, keep the same circuit as we are doing for other patients. You don't have to routinely change the circuit. And ventilator circuits are usually having high concentration of pathogens, so which may induce VAP. Therefore, these condensate, these secretions should be removed regularly. So whenever you are disconnecting the circuit, this is another point you should be very, very clear. A COVID patient, whenever you are disconnecting, either to change the filter or to put a closed section or to remove the closed section or to put a expiratory filter, you have to always put the ventilator on standby. Then you just keep a little bit distance away from the patient. Then you connect all these gadgets. Okay. Otherwise, don't open the circuit when the ventilator is on, because there will be huge aerosol generation. You are likely to get infected. The closed section is always preferred. I've already told. The place filter in both inspiratory and expiratory end of the ventilator. Replace the filters if the resistance is increasing. This is a very, very common mistake nowadays, what we are observing in the ICUs. Like, you will be putting the patient on a viral filter. Somebody will be giving nebulization. Obviously, when you nebulize using the filters, these filters will get more clogged and the resistance will increase. Obviously, the ventilator won't be able to push the air through that filter. Your airway pressures will go high. So any patient, if you see the airway pressure is going high, that means you have to change the the filter. The same way, one filter at the maximum you can keep it for 1 day, not more than that. You will have to change the filter every day. So you if the respiratory the resistance is increasing, the pressures are going high, definitely you will have to change the filters. Now, what are the after ventilating a COVID patient? How you are going to disinfect your ventilator? Again, a very commonly asked question. So first thing what you have to do is you have to do the surface disinfection, just like the previously what we are using, like Incidor, whatever solution you are using, or you can hypochlorite you can use, or like a 70% more spirit you can use. Whatever solution your hospital infection control policy is there to cleaning the equipments or surface cleaning, the same thing can be used for cleaning the ventilator surfaces. Okay. You have to the breathing circuit, etc. You have to dispose it as a medical waste. The patient, usually the ventilator will be having an inspiratory and expiratory valve. So if the patient is usually will be having an inspiratory valve, the components of the ventilator that need to be cleaned or disinfected are mainly the flow sensors located in the exhalation valve and the expiratory side of the ventilator. So from the inspiratory side, you are pushing the air out. So there is no chance of the machine getting infected. The expiratory part also, you have already put the filter at 2 points. So it's unlikely that the machine will get soiled or the contaminated. Still, if the ventilator is having an expiratory side wall, you can remove that and clean it. Okay, if it is a removable wall, the cleaning you can do it with a ETO sterilization.
Very extensive lecture on the most sorted out topic on ARDS, COVID, and ARDS in COVID patient. Thank you very much, sir. It's very exhaustive, and I think it's packed with information, and it will be really useful for our participants, which will be insightful as well as actionable for them. So, during Dr. Sanesh's session, the poll questions were there. We will take the poll questions now.
Okay. Coming to the first question, what action you will take if the patient becomes agitated during a spontaneous awakening trial or spontaneous breathing trial? Option A, heavily resedate. Option B, resedate to RAS of -1, titrate RAS -1 and return to previous ventilator settings. Option D, continue with the spontaneous awakening trial and SBT. How was the response?
The majority, almost 70% of the participants have voted for option C.
C, right? Okay. I think that seems to be the most sensible answer, because we need to return to the previous settings and we need to keep the patient slightly sedated. And one more thing, during weaning, anytime SBT failure, you have to check whether it is due to an acute cause like a fever or any painful procedure and all. Then in that case, you can reattempt SBT later on the same day itself. Otherwise, you attempt on the next day. So you down titrate the sedation as much as possible. Okay, so this is the practice. Do not over sedate just because SBT is failed. Okay. Second question, pick out the wrong statement regarding COPD ventilation management. The disease may not have a reversible component. Yes. Quantifying dynamic hyperinflation at bedside is very difficult. True. COPD patients may be difficult to wean. True. The outcome is same as for acute asthma exacerbation patient. That is the wrong statement, because the background pathophysiology is different. Asthma, it's acute onset and it's almost fully reversible and it comes on and off. But COPD is a progressive persistent deterioration, and you will not come back to the base or the starting point after each exacerbation. So with time, you are going to get worse only. So that's why the outcome cannot be the same. How was the response from our audience?
Almost 60% of the participants have voted for choice D, sir.
Yeah, okay.
They have selected the right choice.
Yeah, basically everybody agrees that asthma and COPD, there are some common things, but outcome may not be the same. Third question, which of the following statement or statements are true regarding Auto-PEEP? Low tidal volume, decreased respiratory rate. Yes, I have explained with the rationale behind those. Increased expiratory time, because we have to give more time because of the inadequate emptying of the alveoli. Addition of extrinsic PEEP to an extent always helps in the inspiratory effort. So to avoid the missed breaths and increased workout breathing, you always add around 50 to 80% of the measured intrinsic PEEP as extrinsic PEEP. So I think option D, all of the above, should be the best statement among these. How was the response, Dr. Prabhu?
Yeah, more than 75% of our participants have opted for choice D, sir. All of the above is what they had selected.
Fine. So the single best response, you need to get the best response. Option A is also correct, B is also correct, C is also correct. So all of the above should be the best option. I think then we'll take the remaining questions in the chat also.
Yes, sir. So we have got few questions for both Dr. Anoop and Dr. Saneesh. Let me take the questions. So now we will move to the Q&A session. There are some questions to repeat certain part of the session. I think we would like to redirect the participants. There will be a recorded session. which will be made available to all of the registered participants. The link will be provided. You can have a check on that, as well as the recorded session is already available on campus webinar session, which is hosted jointly by Dr. Anoop and Saneesh. It is available in their YouTube channel as well. So in the interest
that is
of
the
time,
beauty of this learning platform. So the repeatability, and you can view it according to your timing. Though live interaction gives a different feel. You can directly interact with the speaker or faculty.
what is the ideal target for static compliance value? Is there any defined value which they should target?
Usually we don't target at a compliance, but nowadays, as I've told, with an Armato trial, we target at a driving pressure. So even though I've already told like what are the concepts in ARDS ventilation, everything is important, but most importance we are giving for the driving pressure nowadays. Obviously, we have to look at the pleural pressure, like other pressures also. But you cannot target a static compliance, a particular value and ventilate. It's not possible. So don't worry about the static compliance. This is to give you an idea about the recruitability, whether the lungs are getting recruited better with the PEEP. You don't have to target a particular value of compliance.
Thank you, sir. When should we use an incremental PEEP trial, and when should we use a decremental PEEP trial? Is there any recommendation?
No, both are equally good. I have told there are two methods. So when we use this, I have already given you two situations. Suppose we are ventilating a patient with starting with a 7 PEEP. Your oxygenation is low. So you gradually increase the PEEP and see whether the patient oxygenation is getting maintained. Suppose if you see that a patient who is already on NIV, other treatment for like a more time, you have slightly delayed the intubation, where you feel that the lung is more recruitable. So in that case, if you like do a recruitable maneuver, you are already doing with a high PEEP or a high pressure. So that situation, you can gradually reduce the PEEP and see what is the optimal PEEP. Other situation, you just gradually increase the PEEP and go for a incremental titration. Very simple.
Are there any changes in the mechanics of the alveoli when we are doing incremental PEEP, where we are actually opening the alveoli, whereas on the other side, when we are decrementing, we already opened it and coming down towards the closing pressure?
No, we are just finding out at what pressure the more alveoli are getting opened up. So whether you start from a higher pressure or a lower pressure, it is immaterial. So the question what is asked is, like if you based on the concept in your question, every patient should be recruited. That is the highest pressure you use, and then you come down. But clinically, when that was compared, the evidence for the recruitment is not very strong. So we don't have to recruit all patients and come with a decremental PEEP trial. We can very well use an incremental PEEP trial. That is the one which we usually do in our bedside. But as I've told, there are particular group of patients who are definitely going to improve with a recruitment. Such group of patients, definitely you can go with a decremental trial. So forget about whether you do an incremental or a decremental. This I was just trying to give you two methods. The concept of like G has so many advanced technique of like an FRC calculation or other like the esophageal pressure calculation, etc., for the best optimal PEEP. So there are many methods. Don't think this is the final word. This is one of the methods to titrate the PEEP.
Okay, sir. What is the interval time between incremental maneuver of PEEP?
Now that I've already answered. There is nothing like a fixed time period. I think we can wait for about 5 or 10 minutes with each PEEP value. Then you see what is the change happening. And you look at oxygenation also.
Okay, then. There's a question from Anoop Kumar. Can hypoxemic patient be managed with low tidal volume?
There is nothing to do with hypoxemia and low tidal volume. The tidal volume and the respiratory rate, which corresponds to the minute ventilation and the total ventilation. So the tidal volume and the minute ventilation will help you to manipulate the CO2 values. I've already told you don't bother about CO2 values too much. look at the pH and nothing to do with the oxygenation. Sometimes like as more lungs are recruited when you use a higher pressure, it is possible like you might have observed when you use a higher tidal volume, the oxygenation is improving. That is only because of recruitment happening. But we cannot keep with a higher tidal volume, which we have already discussed with the ARDS trial and all. What is the higher mortality with the higher tidal volume? So you have to use a low tidal volume. There is no doubt about that.
Yeah, discussed extensively about the ROX index. There's a question from Manas Pratim or Thakur. Sir, if we use ROX index for HFNC in COVID patients, will it not be falsely calculated as patients might have normal SpO2 even with severe hypoxemia, like happy hypoxia? What about using modified ROX index?
So there are different ways. Like I am not saying that ROX index is the final word. There are many issues like you have to compare everything. But even when the patient is having a happy hypoxemia, I have already told, if the ROX index are very low and patient is generating a huge tidal volume and a high respiratory rate, definitely that patient is developing PCL and will be having more lung injury. The ROX index has different interpretations. So that is why all patients in your unit, you should have one method of assessment like at frequent intervals to see whether the patient is tolerating that or not. You should not assess it based on SpO2 alone, like the way you are told. That if you are going to do, definitely you may give more silly to the patient and more lung injury. So please don't do that.
What could
Yes,
be the cause of subcutaneous emphysema in the
COPD.
question is not clear. Okay, the COPD. The question is not clear here.
Any case like when there is a rupture of these small alveoli, definitely there can be like subcutaneous emphysema. So with any positive pressure ventilation that can happen with COPD, ARDS, or any other ways also, so it is possible.
Steroids to be started if SpO2 is less than 94%.
No, that is a
What?
misconcept. That is a misconcept I've already told. The steroid, the main evidence, whatever trials we have, so none of the trials have shown that all hypoxemic patients are going to benefit with steroid. The steroids are beneficial only in patients who are requiring ventilatory devices like NIV, HFNC, or on mechanical ventilation. So, like everybody is having a tendency now, if the saturation is somewhere around 96, you start the patient on steroid. No, it should not be like that. If the patient is having like a significant oxygen requirement, even for that we don't have an evidence. Only patients on HFNC, NIV, or mechanical ventilation. These are the three groups of patients who are having evidence for steroid use. Or obviously the inflammatory responses.
Okay, sir. So there's a question on, as an intensivist, which one is most important of the time should be adapted for best result in COVID patient, HFNC or mechanical ventilation? Generic question by Dr. Chandrasekhar.
There is nothing like a proper this thing like HFNC or NIV or mechanical ventilation. Everything has a role in COVID management. So there are a group of patients who will definitely benefit with HFNC, who are other group who are going to benefit with an NIV. But those two groups, if you are not getting benefited, you have to clinically assess and decide about intubation, and please don't delay the intubation. So as an experienced intensivist, you should try to assess at what point you have to intubate the patient. That obviously you need experience. That is why the units who are managed by good intensivists are having a very, very good outcome in COVID management. So the mortality among intubated patients in such units are around 30% only. But whereas like all other units managed by non-intensivists or those who are not having any ICU experience, the mortality rate is very high. The main reason is they don't know how to ventilate and they don't know when to invasively ventilate.
That's it, sir. I don't have many questions on that. I think we have come to the end of this session.
I think COPD everybody has understood very well. That's why there is no doubt on COPD.
There are questions on settings and with respect to the general things like where the filter should be connected or other operational things.
Those
I
things
think
we have already explained, I think.
Yeah. Even the last session we had something on expiratory time, Auto-PEEP and things like that. So this time we reinforced on a COPD background, all these settings.
So thank you, sir. Thank you very much for this excellent presentation from both the speakers. Now we had come to the end of this 3-part series. So on behalf of GE Healthcare, we profoundly thank both our esteemed speakers, Dr. Anoop and Dr. Saneesh, for their fantastic presentation in the past 3 series, Elevate Ventilator Management Experience. So they had delivered the most important concept in this era of pandemic, covering basics, ventilator management, the advanced concept, as well as COVID-related information, spanning over 3 series, devoting more than 6 hours of their valuable time for this series. So we believe the information-packed module delivered by Dr. Anoop and Dr. Saneesh is extremely useful for our participants, and we have provided them with insights, and I think they have provided with insights that are actionable and be implemented in their ICU practice. So finally, we thank all our participants from India, Bangladesh, Nepal, and Sri Lanka for showing your support, making this event a grand successful one. Your participation encourages and motivates us to plan for such useful sessions in the future as well. We are conducting a webinar session on. Yes, sir.
Yes, 1 minute. Many persons were texting me on a certificate. So please, like how you are going to distribute the certificate also, please tell them.
Sure, sir. The certificates, I think I would request Arpita to come in.
So we will be distributing, it will all be an e-certificate with of course the signatures, and we will be distributing it via the email, and so it should hit your inbox really soon. We are on it. Thank you so much.
Yeah, we are conducting a webinar session on 27th at 10 a.m. to 1 p.m. on September on dynamics of anesthesia, low flow, and understanding workstation by Dr. Amit Shah and Apex Patwa. We request our participants to register for that session as well and attend it to make it a huge success as well, to gain good insights about the low flow anesthesia. And as mentioned, the recorded session will be available. All the registered participants will get the link soon, along with the certificate. You can actually view it from the G channel, or which is already loaded in the webinar campus, sorry, campus webinar by Dr. Anoop and Saneesh. That is already available for your for you to go through it in case if you have any concepts to be rehearsed or refreshed. So we once again thank our speaker for this for giving us your valuable time and this very informative session. So we are really thankful to both Dr. Anoop and Saneesh. And with that, we come to an end of this session. On behalf of GE, we would like to thank all our participants and audiences. So is there any final word, Dr. Anoop and Saneesh, you would like to give to our audiences?
We have just given you an idea about the ventilation. This is just a beginning. So you have to gain interest about mechanical ventilation after hearing this thing, and definitely that interest should make you read more and understand more about ventilation. This is learning is a continuous process. Like as everyone knows, like there are new modalities coming up in ventilation. The technologies are improving, so you will have to update it based on that. Don't think this is the final thing in ventilation, but these are the basic things. So once you have a strong base, it is very easy to build over that base. That is what we aim by this program.
So one final question which just came in. Is there any role of fibrinolytics at any stage in COVID-19 management?
There is no evidence for that. Like if you mean like any like N-acetylcysteine or something like that, there is no evidence for that.
Thank you, sir. And Dr. Saneesh, your final words, sir.
Yeah, thank you very much. Actually, I enjoyed preparing for all these 3 sessions, and I enjoyed the lectures by Dr. Anoop also. And I thank wholeheartedly to the team, technical team, and especially Dr. Prabhu and Arpita, who spent a lot of their time preparing for this webinar. Thanks a lot, and have a nice day.